Welcome to Beyond the Frontline podcast, where your host, U.S. Air Force veteran Donna Hoffmeyer, will help you transition from the front line to the home front. Listen every other Wednesday as we'll bring great conversations, resources, tips, and feel-good stories that will resonate and relate. Now, here's your host, Donna Hoffmeyer.
Hey everybody, it's Donna with another week of Beyond the Frontline. It's a fabulous, fabulous day. And this week we're going to talk about, my voice is still squeaking. I'm at the end of my cold, but yet it still got me. But this week we're going to talk about modalities in therapy that do not involve talk. And I will just tell you that with my background as a nurse in the military, in my last 5 years, I actually worked heavily in the mental health world, helping people get mental health care. And I started to really understand that talk therapy, there's always a place for it. I'm never going to knock that. I think it's really great. But there's actually other modalities that people can do when talk is not an option, when it's too stressful for them. And so one of those modalities we're going to talk about is EMDR. And I have today a very special person with EMDR, Dr. Sheila McHenry. And Dr. Sheila, as she goes by, is the president and clinical director of Smithson Valley Counseling out here in the Spring Branch area in Texas. And for those of you that don't really understand EMDR, we're going to go through that. A lot of people have heard about it, but it's a really neat modality that we can utilize to process trauma when things like talk is just too much, right? So, Dr. Sheila, you are here with me today, and I'm super excited. It's nice to have you.
Thank you. It's good to be here.
Yeah. So let's talk. Oh, actually, I want to talk about a fun fact about you. So EMDR was developed by Francine Shapiro. I always say Francis for some reason. And there you go. And you were one of the last students that she had, correct?
Well, for level 1 and level 2. So after my class, then she continued to teach level 2, but she passed level 1 on to some of the people who were in her training group.
That's cool. All right. So from a historical perspective, explain, because I think the story is kind of fascinating, how EMDR kind of came to be, what it is and how it came to be.
So Dr. Shapiro shared a story in her training about walking through a park. I want to say it was over in Marin somewhere. And she said she was walking a path, and she was thinking about some troubling things from her childhood. And she noticed that the emotions were lightening up. And so she stopped and tried to figure out what she was doing. And actually it may have been that first she thought of another troubling thing. I can't remember the order, but anyway, she was trying to figure out what's different about this walk. And she said she realized she was moving her eyes from one side of the path to the other. And so she wondered, because she had walked that path many times, if it was the eye movement that moved the emotions. So she then thought of another thing that had a negative residual on it, and then added the eye movement, and it also shifted. And she said she turned around, ran back to her car, rode into the office, got all the clinicians in, and said, think of something that bothers you, and now move your eyes. And they were all kind of looking at her like, what do you mean move your eyes? And she said, she held up her fingers, and she said to somebody, follow my fingers. And that literally was the birth of EMDR, because the clinicians in the room also got some relief.
It
was amazing.
To have that kind of self-awareness. I mean, she was already a therapist,
right,
and that was her background, but to still connect that's some serious self-awareness.
Isn't it?
Yeah.
Isn't it?
That's
and then they got a grant to work with the veterans, the Vietnam veterans who were still living up in John Muir Woods. Mm-hmm. And she talks about this story as well, that when they came back from Vietnam, they were not able to acclimate back into city life. So they were literally living up in the woods. And she got a grant to work with that population. and was working with them, and she just talked about, the lack of coping, the lack of resiliency, the triggering. A helicopter would fly over and they'd be under the desk. Just totally traumatized, and lots of triggers. But once they started doing EMDR with this population, she said that they would notice improved functioning, them being able to come back in with maybe clean clothes or a dress shirt or a haircut. And then also noticing that if the helicopter flew over, they were continuing to converse with her. They were no longer diving for cover. And she would be the one to point out to them, did you even notice that? And they would say, like, notice what? Yeah.
So they weren't even aware
Exactly,
that there was
because
this improvement.
Exactly. It just became, again, like for most of us, right?
Yeah.
Background noise.
Which is where you want it to be.
Exactly.
I mean, that's the whole point.
Exactly.
Well, let's start with, what does EMDR stand for?
Eye movement desensitization and reprocessing. And EMDR, remember what I said, she was walking the path and moving her eyes from one side to the other.
Yeah.
And so the original EMDR was eye movement. So it was literally, and you can see these videos where people will still like track either a light source or following fingers. So the original way of doing EMDR was, and the way I was trained, was following the fingers.
Right.
And since then, because I ended up with somebody who had retinal problems, and you're not supposed to do EMDR with retinal issues. So after that client, I went to hand taps, where
So you could audio.
Oh, you can do audio. You
Okay.
can do hand taps in terms of having the clients sit with their hands on their knees.
Okay.
And I probably did it that way, from the late, I would say middle to late 90s all the way through really the TheraTappers coming into play, which was probably like the last 4 years or so.
And those are actually handheld, right?
Correct. So EMDR is a bilateral therapy. So it's triggering left and right hemispheres, as we understand it. And it kind of ties back into Bessel van der Kolk's work on trauma and how trauma is held in the body.
So a lot of people will know that they may hear the name and not connect, but everybody that has had some level of therapy for trauma probably has heard The Body Keeps the Score. Bingo. And he's the author of that. Right. Yeah.
Right.
So that's,
and I'm being hats off, because he is a brilliant researcher.
He wrote it in a way, because I've read it also, and he wrote it in such a way that it literally teeters the line between the layperson and the clinician. So, like, maybe the layperson doesn't understand every little bit of it, but I will tell you, you're going to get 80-90% of that. I mean, and how he gets into these different modalities. Like, he's a huge fan of also a lot of non-talk modalities. So, yeah. I mean, after I read that, I was like, oh, this is really well written, because the layperson can read it. And I know a lot of therapists that refer the book. They tell people, like, read this book, and it gives them some really good insight on that.
And it demystifies what's happening.
So, well, speaking of that, in EMDR, so you started to talk about, like, what's happening with the brain. So when you're doing this and your eyes are moving, it's not hypnosis. What is happening in our noggin here?
So again, like with the eye movement, and with any of the bilateral therapies, we're triggering left and right hemispheres. And so knowing that, we have that logical half of our brain, we have the emotional half of the brain. And one of the things that Bessel van der Kolk had found is that when trauma is active in the brain, so when a traumatic trigger is happening, the brain shifts. And so corpus callosum, the bridge between the left and the right hemispheres, shuts down. Prefrontal cortex shuts down. Broca's, which is the speech center, shuts down. And the hypothalamus, goes into overdrive. So we end up with the adrenaline dump. We end up with the fight or flight response. And we got everything in the brain geared towards survival.
Is that also where cortisol, they found the low levels, like they're dumping their cortisol too? Is that related, or is that?
I would imagine it is, but
Yeah.
I don't know that specific link.
Yeah.
Yeah, but it would make sense.
Makes sense. Yeah, that they're dumping it.
So, so the EMDR, being a bilateral therapy, one of the what would you call it, hypotheses, is that when we are triggering left and right hemispheres, what we are doing is reactivating or bridging the corpus callosum, which allows the emotions and the logic, right, to reconnect. So one of the things people will say is, why am I feeling like this? Why am I acting like this? I know better. I shouldn't be doing this. I shouldn't be feeling this way. I shouldn't be thinking this way.
Because we're not connected.
Because they're not connected.
Emotion and logic
their
are not.
logical brain knows, okay, it's over, right? But the emotional brain is going, this isn't over. It's here and now.
We're just starting.
Because the body is saying
Yeah.
it's here and now. So in the EMDR, what we're doing is we're bridging the distance between the logical brain and the emotional brain. It's fascinating.
That is fascinating. Well, I was just having the thought in my head, like when they're disconnected, the logical is like, hey, don't do this. And the emotional side's like, hold my beer. We got you.
It would be great if that was the case, but a lot of times it's the emotional brain's like stomping on the brakes going, I'm not sure I want to go here, right?
And they're like, hold tight. We'll
show
you.
Yeah, exactly.
So that disconnect happens. That's like what you said. You have that. If I'm correct in this, that's where you become reactive instead of responsive, right? Like you just
perfectly stated.
React, and that's where you get people like you and I've had this discussion before where like, the person is like, yeah, and then I pulled over and I got out of my car and like we're all looking at them like, oh Lord, because we know like you're reacting, your brain's hijacking you, and you're not responding, you're not thinking through that. But now that makes complete sense because there's no connection in there, and so we're recreating the bridge.
Right.
Yeah,
right.
That makes complete sense. And here's the cool part about it. I said this in the beginning. This has just been like ever since I kind of learned about all the different modalities, it's something that's been building and connecting in my head is like, we know this about veterans and our first responders, that some of them have seen such trauma that when you actually have them start talking about it, it can be re-traumatizing to them, correct?
I think what it does is it kind of like pulls everything up. So, see, my brain starts going in 5 different directions. So, like when you talk about an activation, like a trauma can stay dormant until it's activated. And so, it's like somebody can say, I'm doing fine, right? But then they can be out and about. There may be something that they hear, something that they smell. There can be something that they see. That input will reactivate what I call the trauma bubble, all of the information that is held in that traumatic experience. One of the things that Bessel also talked about was that when we have a traumatic event, that there is this moment when the brain says, oh shit, something's wrong. And at that moment, the brain switches from its day-to-day functioning into survival
mode.
And it will stay in survival mode until the trauma is resolved or over, until the brain can now say, it's over, I'm safe. So all of the information that is in that space between, oh shit, something's wrong, and it's over, all of that is stored in the brain differently than our day-to-day stuff.
We've seen that, and I've seen it 1,000 times. I mean, flashbacks, right? With people. I actually had a service member that I got a call from, and there was the therapist, and they said, ma'am, we had a little situation. And I don't know if it was like door slam or a yell or something sudden happened, and it was within this clinic. And the service member was going in for his therapy, And the next thing you know, he dove and he's telling everybody, get down for cover, get down for cover, get down for cover. And like everybody's like, what? And of course, therapists realized what was happening and just made sure he was safe until he, it all ended, and then brought him in and, they worked on it. But she just wanted to let me know. I've seen it 1,000 times. My husband, actually, we used to have a huge debate about PTSD. And he would be, he kind of was of the sort of the mindset, like, how is it affecting some people and not others? And he's really pragmatic, right? So he's thinking through this logically. And I'm like, if we had the answer, whoever had that answer that could predict it would be the bazillionaire. I said, that is the problem. We don't know. And so interestingly, I don't know, 6 months later, there was one of his peers, it was another service member. They'd both deployed equally. They had both, the only difference between them was my husband had been a paramedic before, and this guy had not. And so when they were deployed, they would call for people to help with transport. My husband's like, I've done plenty of that. And so other people had never done it. It was like going to help the CASIF and help move patients and transport them, right? He goes, that's probably about the biggest difference between the two of us. He goes, but I've had that background. So I've already experienced that also, right? And he goes, so scroll ahead, he comes home. Guy's fine, everybody's doing fine. His daughter ends up in a car accident. And he goes, at the end of the day, she was going to be fine. She was a little banged up. And his buddy said, as soon as I saw her, and there was a little bit of blood, he said that was it. And my husband's like, Donna, he was like a 180. Like he literally went from fine to medically boarded out of the military. And he looked at me and I'm like, that is what I'm talking about, right? We don't know that answer.
And we don't have a clear answer on what is activating the resiliency, what builds into resiliency. And yet, we're finding out more and more about the vagus nerve, recovery, things that we can do to help calm the body. But, EMDR is for those events, and they can be known and not known. I want to be clear on that, because sometimes people may have a body response or a negative cognition, a negative thought, negative belief, and they don't know what it's tied to. But it goes back to, I should know better. I shouldn't be thinking this. I shouldn't be feeling this way. So with EMDR, one of the things that Dr. Shapiro talked about was, we're looking for the event, we're looking for the negative belief or cognition associated with it. We're looking for the emotions and the location of those emotions in the body. So those become the things that we tie together so that we can launch the EMDR.
It's all the things that as veterans and first responders, we suck the most at, because we're good at the opposite, compartmentalizing.
Bingo. So if your training, right, is compartmentalize. Put it in the storeroom, put it it away.
Yeah, you have to.
Yeah, then you end up with the full storeroom, and then there's no more room.
Filling out the back room, and we've got it all. Yeah. So the whole thing is that people don't have to talk. You don't have to say, hey, I was in this firefight, and something happened, we don't have to say that. So how does it look to walk through this?
So before we jump there,
okay, sure.
Let's say that somebody comes in and says, like I'm thinking about one person who said, I keep smelling diesel. And they're not anywhere near diesel. So we targeted that, and it uncovered a whole trauma. But we only had the somatic. We only had the brain remembering a
diesel
smell. And the brain, there may be, again, something in the body, that is activating, could be like a sudden sharp pain. That was another one that was targeted. And again, there was a trauma that was being held in the body, and that body memory was the tip of the iceberg for us to go in and uncover a whole trauma associated with that one residual.
Wow. So I got like 14 questions. This is my squirrel brain. Like 14 questions
Join
in
the
my head.
club.
I know. This is why we get along, right? We follow each other's squirrel brains. I know. So, well, let me ask this first. What is the process? So you said sometimes it could be like one identifier and they don't even know what the trauma is. Maybe they find out later. So how does it work? Just tell us how the process, if somebody comes in and you're going to do EMDR, how does that work?
Well, we again, and a lot of times, and most of the time, right, we know, or the client knows, that there is a trauma that is bothersome.
Right. It's impacting their life.
Yes.
Yeah.
And so one of the things that, again, kind of like the protocol talks about, again, the picture, the negative cognition, the emotions, and the location of the emotions. So whatever components the client can share, like you had said, like I was in a firefight, or I was attacked in the medical unit.
Yeah.
I was, whatever it might be. So once we start the EMDR, now I use TheraTappers now, so the client will hold the TheraTappers, which will throb left hand, right hand, left hand. It's like a little paddle, mini paddle. And so, again, bilateral. It's stimulating one side of the brain, then the other side of the brain.
Just for the record, it's not shocking anybody.
No. Yeah, and somebody goes, "What is this reading?" I go, "It's not reading. It's just throbbing."
Right.
You know what I mean? So now, see, now my squirrel brain just so the client will hold the TheraTappers, and what I will tell the client is you can share as much or as little as you want, but what I need to know is when everything is calm in your brain, calm in your body, calm emotionally. So we work, and I do EMDR now a little bit differently. I still follow the protocol, but instead of just doing like what I call the Polaroids, what I do is I try to run the movie. So,
okay.
So what I want is I want to capture that moment when the brain said, "Oh shit, something's wrong."
Yeah.
All the way through to when the brain says, "It's over, I'm okay."
Okay.
And I want to capture what's in between that. So I will ask the client to run the movie.
In their mind.
In their mind.
Yeah, they don't have to say it
Don't
unless
have
they
say
choose
it.
to.
Right. But also know that as they detox the memory, and it's not so loaded, it's so much easier to talk about.
Right.
And as soon as we've done that first run of the movie, and we go to run it again, because we will do sequential runs, typically what will happen is the intensity of the negativity will begin to decrease. And things begin to fall off. It's kind of what I call it, kind of like things fall off, but other information highlights. So there can be things that come to mind that people have forgotten, or it's blocked. So the memory begins right away to change. So let's say I'm doing an EMDR on a memory. The first time I run it with the client, it may take them 25 minutes, and I'll kind of mark the clock, and then we'll get to the end. They can share as much or as little as they want. I will ask them what was the intensity, 0 to 10, and then when we retarget, and there's a whole protocol around retargeting, but when they run the movie again the next time, and especially for those who are more comfortable talking, one of the things that right away you notice is that the memory is evolving. There are things that are falling off and things that are highlighting that were not in the first round.
So they have more memory and then some of it kind of fades away?
Yes.
That's
It's more-
interesting.
yeah. So it's evolving, because remember, we want it to all be historical memory.
Right.
Right?
Yeah.
I know it happened, but it's over and I'm okay. So, but the second run may be 20 minutes or 17 minutes.
Right, because you're putting it together.
It's beginning to process. And so each time we run the movie, what I find is that the memory is simplifying, it's detoxing so that the intensity is dropping, and the memory itself is simplifying is the best word, to the point where, yeah, there was this day and blah, 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 and this happened, and yeah, it was really bad, blah, 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 and then we got back to base and everything was okay. And it's like all of the other stuff has moved from, again, that trauma bubble that holds all of the information, all the sounds, all the smells, all the visuals, all the body emotions, all of the somatics, the compression, the whatever it may be.
Yeah.
The position that somebody was in.
Yeah.
Into it becomes almost like an overview with a highlight.
Yeah. I see what you're
And
saying.
then the highlight itself resolves. And then it's like, I'll have people say, well, in order to get back to it, I have to really work at it. I go, I don't want you to work at it.
Right.
What's your awareness?
I'll tell you, that's funny that you say that. I have too many therapist friends. So seriously, I think I got free counseling all the time when I talk to you guys. No, somebody said this to me and it was kind of mind blowing. They said, if somebody is not having, like if they have memories that they think are suppressed, but it is not affecting their daily living, we don't want them to remember it. And I was like, right. Like, and then it kind of led me into, and we're having the issue is because our body is going into a physical and also mental, but response. Like we have the parasympathetic, sympathetic response. Heart rate goes up, respiratory rate goes up, digestion can go up or down, like whatever's going on.
Correct.
And of course, it was a veteran that said this to me. And I laughed because he said, ma'am, he's like, I went to a therapist. And I said, you did? He's like, yeah. And he goes, I had a nightmare. And the therapist was like, well, tell me about the nightmare. And he's like, I looked at her and said, do you want to tell people about your nightmares? Do you want to remember that? Because he had a lot of colorful words when he said it. And I just looked at him and he goes, seriously, ma'am, do you want to talk about your nightmares? He goes, when you have one, does it make you feel good? And I was like, no, like you really don't want to go back and think about it. He goes like, so why do I want to tell somebody about it? And I'm like, that's a fair point.
Well, and it's interesting that you say that because I will EMDR nightmares.
It makes sense though.
Yes.
Because like the whole purpose, I said this to Dr. Ross. I actually ended up working with him with a service member. And Dr. Ross, I don't know if you know him, but he had
Colin Ross?
Huh?
Dr. Colin
Yes.
Ross?
Yeah.
Holy moly.
Yeah. And so
hats off to you.
Yeah. And so I said to him one day, I said, okay, so really all of this, everything we're doing, as complex as smart people are doing, it comes down to this. We feel like crap and we are trying to figure out ways to stop the parasympathetic, sympathetic response. And he goes, that, Donna, is the question. That is the core. How do we stop this? And I'm like, it's that simple. He goes, yeah. So we have all this. We have lots of different options, but they're all trying to do the exact same thing. So whether we are doing behavioral therapy or we're doing post-exposure therapy, or we're doing EMDR, equine therapy, neurofeedback, like every single one is coming, ketamine, to stop the parasympathetic, sympathetic response. When you're doing the ketamine and you're hitting the ganglion, you're literally paralyzed, you're not letting the brain send the response. That's every modality is trying to do the same thing.
Absolutely.
And when it hit me, it was so obvious, but so profound at the same time. It literally changed the way I looked at all of this. And so when I talk to veterans, and I tell everybody straight up, I am not a therapist. I am not, trust me, I have a lot of admiration for you guys. I bring them to you. That is your world. I will never challenge that. But from the outside of it, watching it and looking at all this, when I talk to veterans and first responders, I said, you have a lot of options. I've had people that had good responses to post-exposure. I've had other people, we had to go put on blood pressure medication because it did not work. It was not good for them at all. And so when we approach it, I always tell veterans, and first responders, all of them, gotta start somewhere. If it's not resonating, it is okay. Like, nobody should be knocking you for that. Just like, hey, this isn't working. Post-exposure or talk therapy in general sometimes has a really poor compliance because they have to take a deep breath and get in there and start talking about this. And when it maybe is related to like moral injury and something that happened that they were part of that they just can't get to grips with, talking about it is just too far for them. It is just too far. So it's like, I want to be able to say, hey, it's okay.
Yes.
We've got other things.
Yes. Yes.
What do you see? Like, you have a lot of veterans too.
Yes. And I think that 70 or 80% of our practice is veterans.
Yeah. I keep dragging them to you. That's why. Here's another one.
Yeah. Find your way here. So, but when you talk about like moral injury or processing, remember that the logical brain may be able to say, okay, it was us or them. The situation in the moment required a response, but they're not able to resolve aspects of that trauma.
Yeah.
But one of the things, because of EMDR strengthening the logical brain, remember, eye movement desensitization, that's the affect, the emotion calming. Yeah. Reprocessing is the cognitive. So it can go from a unresolved into resolved with the logical brain coming online and bringing, for lack of a better word, like a hindsight to it, like a fresh perspective, like there wasn't another way through. Mm-hmm. And so the EMDR actually can take what we should know. I should know that.
Right.
I should just know that into, well, of course that's true. So it shifts. So there's a different lens cognitively in the belief system, as well as the emotions calming and the physiological components of the trauma calming.
Yeah, when you don't respond anymore, it's not a thing.
Bingo.
It's so funny. It's like, I hate to say we can boil this all down to when you don't feel like crap, it's not a thing anymore.
That's right.
When you can go like, oh yeah, that happened. Not the best time of my life, but anyway, where are we going out to eat?
Right, right.
Versus,
it's over, I'm okay.
Yeah, I'm still here and I am okay.
I'm alive.
Yeah.
I didn't die.
Yeah, and we are okay, and that happened, and I am able to move forward. All right, I got to ask this. This popped in my head. Do you think? Sorry, let me tell you. I'll preface this. So, a friend of mine, as a workmate, worked at the Joint Chiefs, and she was moving to the JAI, which is the Joint Artificial Intelligence, and I was like, "Ooh, what do you do there?" And she's like, "Oh, it's predictive analysis," and I just kind of bursted out laughing, and I'm like, "Girl, you're not gonna have anybody come in the military if you try to do predictive analysis, because a lot of our best troops are the ones that have had childhood trauma, like we're primed, right? I hate to say that, but a lot of people that come in the military that kind of thrive are primed because they had a rough childhood in some capacity. Now, the problem is that if they haven't handled that, and then they come in with the looking for structure and routine, and we give them all of that, right? The military gives all that. We also give trauma. And so now you're dealing with what we know is like things like complex PTSD, or if they were dealing with anxiety or depression, maybe that gets exacerbated, triggered, whatever. Do you think, sorry, it's dry out here. Do you think EMDR would have a place in places like basic training or anything like that, or maybe before they even come in the military, like doing some kind of, it's resiliency work, like healing that So they're still had issues and they're still looking for that structure and all that, but you're healing some of that. What are your thoughts?
Right. So, yeah, and it's fascinating.
I know.
Fascinating that you brought that up. So, if there is somebody who comes in and they're particularly fragile, one of the things that we're shooting, we have a negative cognition. Negative cognition may be, I'm going to die. Positive cognition, or what I call the landing pad. Where do you want to end this? What do you want your belief to be at the end of this? I am okay. So in the case where somebody is more fragile, what I do is the positive cognition installation. What I'm going to do is I'm going to have them work with, I am okay, holding the TheraTappers. I got through. It's over. So there are things that what I want to do is I want to boost resiliency before we tackle the trauma. And so if I'm feeling like I'm picking up that, there's a little bit too much of a wobble here, then I'm going to start with a positive install and then move towards the trauma.
So recruiters, this could be your best friend, right? Like you're producing or you're giving better quality people. They're still looking for the structure and whatnot because they didn't have that. But now you have them, I am okay, walking into that. I actually had, I cannot remember his name, but it was a psychologist. He was at Columbia University. But anyway, he said to me, we were talking, and he said to me, Donna, can I ask you a question? And I said, sure. And he goes, why doesn't the military want to make their people more resilient before they deploy? Why are you not doing this before? And he was very serious. He just looked at me very quizzical. And I was like, because everything goes to the lowest bidder. I'm like, yeah, joke. But I didn't have that answer. It was an interesting question. He's like, why? There are plenty of things that you can do to make somebody more resilient. So when they go into deployment, when they come back, it's not so tough. And then it kind of led into I work in analogies. My brain is a big old analogy and visuals, right? And so when I see veterans and first responders that are untreated, I see this like oscillation of like big high, like, okay, we're up here. And then boom, real low. And that low could go a day, a week, a month, a lot longer and worse, right? And then somewhere in there, hopefully they start climbing, but maybe they don't climb up as high as before, and maybe they dive even lower, right? So it's this big peak and trough kind of stuff, right? And I always tell them, like, hey, the goal is that when you hit that trough, you don't unpack your bags, you don't stay there, right? We want you to come back up. And so resiliency to me is that you are now oscillating, these gentle oscillations that if the line in the middle was your zero, your neutral, you're doing 10 above and 10 below in a gentle cycle. Maybe some days a little higher, longer, but you're not having these like massive peaks and big old dives.
Yeah, you're not crashing.
Yeah, and you're not crashing. And so that again, it's like that's this goal that I see that we all should, that everybody and the therapists and everybody are working towards. Like, how do we get them oscillating? I mean, some of them are probably square. Jagged.
Yeah. And when you talk about that, that crash, and we track that because that crash is calling out about the trauma associated with that.
Right. What about precognitive years? So somebody that has dissociative identity disorder, and for the audience, some people might know that as multiple personality syndrome. Everybody knew the book Sybil. That's when it was first kind of like really put out there, but now we call it dissociative identity disorder. And my understanding, please correct me, is that DID is developed in the precognitive. So before the age of 5, when there's like before memories, 5 or 6, there's this trauma, significant trauma that happened, but they do not have the memory, the ability to remember mentally, but physically there is that memory. Is that correct?
Well, I think that my lens is a little different. Prior to the age of 6,
Okay.
there is a significant trauma that overwhelms the child.
Okay.
So, and it is life-threatening. So what happens is the child will dissociate. And so they're within the brain, within the processing of the trauma. The trauma will be split off. So it's like there now is a part that knows what has happened, and then there is a part that functions as if nothing has happened.
And that's different than compartmentalizing.
Well, it's extreme compartmentalization because you're looking at the same body. But, I think of, one family that said, yeah, we didn't know when, Dad came home, were we getting, Dr. Jekyll or Mr. Hyde?
Yeah, which is kind of like a sign.
Yeah.
Can EMDR work with that, or is
It can. But one of the things, like when you're doing parts work, it can be a minefield, and that kind of goes into IFS, where you're talking about internal family systems,
Yes.
and you're looking at, a vulnerable or a victim part, you're looking at a protective part, you may be looking at
It's almost like you have to do EMDR with all the parts to kind of get them to...
You got to do EMDR with either all of the parts, or even getting permission to access the system, or the internal system, which is a whole nother bugaboo.
Believe it, I had one client. That's why I was curious. We had a service member that had the idea. That's actually how I got to know Dr. Ross, and he even said he's like, this one's significant. And so when I hear the EMDR part, I'm always like, huh. It's before like you said, it's like before 6, significant. So you go ahead and...
The simpler the system, and when I'm talking about the system, I'm talking about the internal parts. The simpler the system, the more EMDR is the more it can be used effectively.
Do you have to have multiple treatments with EMDR? Like, is it so would it be like one memory that you'd come in maybe?
And the memories can cluster. So, one of the things that when we talk about, say somebody's coming in and they've got multiple traumas, one of the things that Dr. Shapiro had talked about is do your best to start with something in the middle. So we kind of rate the intensity: low intensity, middle intensity, high intensity. Mm-hmm. And so rated from 0 to 10. But one of the things I have found with so many of my veterans is that their 10s are the rest of the world's 15s.
I was just going to say off the chart.
So she said, start with something in the middle. And, but if that 5 intensity trauma is sitting on top of a 10 intensity trauma with similar cognition, body sensation, if there's a tie between them, the EMDR may go right to the 10.
Oh, interesting. Oh, yeah. If there's a connection, that would make sense.
And we don't always know. We don't know what's sitting on top of what. So we may be doing our best to go after the 5, but I am always prepared in the office for a 10 to emerge. And it's like, and what I tell people is, we're going after the 5, but if there's a 10 hiding, we're going to get there eventually anyway.
We try to outdo ourselves for you. Yeah. We go for it. Here you go.
And so, we're going to get there eventually.
Yeah.
But my confidence in EMDR has gotten to the point where it's like, I'm not worried about it. I think early on when I was learning the protocol, it's like, oh, what's going to show up? What's going to show up? And now it's like, whatever shows up, we're going to deal with it.
You're going to handle it. Yeah.
Yeah, absolutely.
You can get right in there.
Absolutely. But there is that, learning the EMDR with something in the middle is a goal.
Yeah.
Because then once you're comfortable and you understand how it works, then what I hear from people is, oh my gosh, when can we do this again?
makes sense. I mean, like again, it's so flippin' simple. Like when you feel better, you're like, oh, I want to try that again. Yeah. And that's why I kind of, I beat the same horse over and over to people. I'm like, you are your advocate. If it does not work, it is okay. It really is okay. Like not everything works for everybody. Don't always knock the therapist. If you don't connect with them, that is also okay. And a good therapist will be like, hey, I totally understand. Let's find you somewhere else, And like anywhere, there's good and bad, you're not going to always hit your mark. But in general, if it doesn't work, and I hit this hard because I think the veterans and probably the first responders, we are put in scenarios where like, that's who you're on patrol with, or that's who you're deploying with. And you're like, oh, yay. Like, I got this one. And it may not be your favorite person, but you got to make it work, right? And that is not the same case when we're out here. Like, if that relationship doesn't work, if it's not working for you, advocate and just be like, hey, this isn't working. I was just telling you, I had a veteran that did that. Like, oh, it didn't work. And this, I'm like, okay, well, did you go back and talk to them, the clinic, to get somebody else? And they kind of looked at me like, oh, like you can tell it doesn't connect that dot. Like, oh, I can do that. You're not going to go to jail. Nobody's going to yell at you. You don't have to be a douchebag about it. You can just be like, hey, this isn't working. Could I have somebody else? Do it. Advocate.
Absolutely.
Advocate.
And there's going to be different, like within the EMDR community, clinical community.
Yeah.
You're going to have a huge disparity in experience. Mm-hmm. And the therapist has to be able to tolerate what is emerging in the room.
Yeah. Can they handle it? And I'm going to speak to this real quick and then we'll wrap this up. But explain to people the difference between, I'm going to say for an analogy, garden variety therapist, right? And a trauma-informed therapist. Because one, I know we don't have enough of the trauma-informed. But can you explain the difference and when somebody would do better with one over the other?
Well, again, kind of like looking at what is somebody coming in for? I mean, are they coming in for, a marital issue, right? Or communication work, or parenting skills, or a residual, so to speak, as opposed to somebody who is looking at a full storeroom of negative events.
Yeah.
And it's almost as clinicians, you learn to hear behind what's being said. You learn to hear what is being said, but you learn to hear what's under it. And there will start to be like an awareness of, okay, we're talking about this layer, but what I'm actually feeling, and a lot of times it comes up in my body, where what I will pick up is, we're maybe talking about this, but that's not what we're talking about.
Yeah, instinctually, you have to go deeper.
Yes, and it's very, but again, I'm not going to try and read somebody's mail. What I'm going to do is extend curiosity.
Yeah.
And I'm wondering, we're talking about this, but I feel like there's something else that we're not quite naming.
Yeah.
And I think that, I remember somebody told me, you over-listen. And I said, well, I'm sorry. And she said, no, I like it. And I go, well, what is it? And she goes, you hear behind what I say.
Yeah, you read between the lines or hear between the words. And so.
Over-listen.
Well,
thought,
and
my gosh.
And the reason why I say that is because a lot of veterans, first responders are dealing with this trauma. And because we're really, really good at packing it away, a trauma-informed therapist is going to cut through this a lot quicker. And I am not when I say garden variety, that is not a derogatory thing. When I say that, I'm just saying as a difference that I have had really good therapists like, hey, I actually don't do that higher trauma level. That is their choice. I stick with marriage counseling, the lighter things. That is where I prefer to be. Absolutely fine. The best therapists are the ones that know where their strengths are, know where they're at, know where they're comfortable, and know when to move them on. And sometimes you can go work trauma-informed stuff, and then go back to the residual and go to a different therapist. I mean, that's not wrong, So I say that because, one, we definitely don't have enough trauma-informed therapists. And two, again, it's back to advocating and knowing what you need,
Right.
and learning.
Right. But and I think that like any other skill, there's a lot of trauma in our communities, in our population.
Yes.
And even as an MFT intern, it was like I was told in my master's level program, like, don't worry about MPD, multiple personalities. It's 1 in a million. You'll never see it.
How many have you seen?
A lot.
Yeah. It's way more prevalent
Right.
than people realize.
Right. And I had 2 as an intern.
Oh, I thought you were going to say as a married couple.
No. No. As an intern. And it was like a little bit, so it was more like baptism by fire.
Mm-hmm.
I mean, I had to learn.
Yeah.
I had to learn, and I had to learn fast.
Yeah.
So then when I went back, for my doctorate, then that became my focus of study for my clinical case dissertation, is working with the more profound dissociative traumas.
Yes.
And so, but I think that as clinicians, you either recognize what's coming into the room and you learn how to deal with it, or you don't.
Or you refer them.
Right.
I mean,
Right.
That's just a reality.
That is.
Yeah.
That is.
And again, I don't think there's anything wrong with any of it. I think you should know. If you don't, the repercussions are hard. I had a situation where the therapist thought she could handle more than she did. And I'm going to tell you, we got in a pickle when she decides to go do a wellness check by herself. It's one of my service members. The person has DID. One of his alters was a Russian MMA fighter. Worked with the Russian mob. I couldn't make this up if you paid me. But long story short, I was like extremely worried. I'm literally trying to call the police to be there. She's like, no, I got this. No. Like, know where you're at, right? I know a lot of phenomenal therapists in all different varieties. And when they're like, hey, I'm here, respected, got it, like that. So on both sides. So I kind of ran us down this rabbit hole because I want people to understand that there's a ton of good therapists out there. And they got to meet you where you're at, and you have to meet them where they're at. And if it's not a match, you get to go on to something else. And the other part, which is the whole purpose of this podcast, was specifically there are also all these other modalities. And the one we focused on today was the EMDR, because it's so beneficial. You don't have to talk about it. And here's the cool thing. You could have a specific situation that maybe you can't handle talking about, and you do it with EMDR, but maybe there's other parts that you do better talking about it, right? I mean, we have the option to do it a variety of ways, and I just want people to get the courage to try it out, try different things out and ask the questions.
And one of the things, like when we talk about, like with the EMDR, I will say you can share as much or as little as you want.
Yeah.
And at the end of the running the movie, remember, safety to safety, from that moment when it's like the crap's hitting the fan to when it's over and I'm safe. When we run that, I will tell the client, you can summarize or kind of like give me a thumbnail sketch of what came up.
Yeah.
So that I can track the moving and the resolution of the memory.
Yeah. That's pretty cool.
So they can talk their way through. And I will say most people talk their way through. Or they can just notice and attend and process and then give me what was the intensity. And again, that thumbnail sketch of what they were processing.
That's good. I like that. All right. What are some last thoughts? Anything you want to share with the audience?
I'm hoping this is helpful, that it helps people understand.
Mm-hmm.
And then one of the other things, like at our clinic, like you talked about, like some of our therapists, like really like working with kids.
Yeah.
And some of our therapists really like working with adults. But when somebody calls in, the admin knows who's trauma informed, who can work with the higher complexity cases, and who is more of that garden variety or, you know, day-to-day stuff, you know. And so somebody doesn't have to do the work on their side to figure out when they're calling in. Yeah, I mean, our bios are up on the web.
Yeah.
But we know to direct our clients to the therapists who deal with the more complex issues.
Yeah, they make the best match, so that you don't have to like stress out like, oh my God, how am I going to know? Like, you train your front office to know who is what and the best person for the job, which is good.
Yeah.
Where can people find more information about you guys?
On the web at smithsonvalleycounseling.com. And we are in Bulverde. It's a Bulverde address.
Yes.
But we're in the Bulverde Spring Branch area, maybe 10 minutes from San Antonio?
Pretty much. It's perfect. All right, everybody. I think that concludes this. I hope you guys got a lot out of it. My biggest thing is just there's a lot out there for you guys. There is a lot of good care out there. It's all over the place. If you want to know more about EMDR, honestly, there's actually, Dr. Sheila, what's
EMDRIA.
There we go.
EMDRIA, and I think it's emdria.org. And that is Francine's, she's passed now, but that was the organization she started. So the EMDR International Association.
That's the one I was thinking of. And you can go right there and literally look it up and find an EMDR person in your area. So I want you guys to get brave and step out there and try these different modalities, because honestly, it's only going to benefit you. And I think anything where you have the option to share as much as for us, any coming home well, we want you guys to share, like, talk about it, ask questions, do all those fun things. And we hope you guys have an awesome week.
Thanks for listening to Beyond the Frontline, a podcast of coming home well. Join us every other Wednesday. And if you enjoyed this episode, please share it with others, post about it on social media, or leave a rating and review. Thanks again. And until all are home and all are well.